Good afternoon, everybody. I'm Greg Simon, and we're here today to talk about you by talking about early cancer detection. The point of this panel is to talk about how we get cancer before cancer gets you. Everybody has cancer happening all the time, but usually your immune system takes care of it. When, for whatever reason, it doesn't take care of it, we need to be able to find it early because most cancers can be defeated if we find them early enough. And the problem we've had in the history of cancer is that most of the patients we see are in late-stage cancer because we couldn't see the beginning of cancer. Now, part of the problem of seeing the beginning of cancer is that the biggest hurdle, the technological hurdle, is the human brain. I follow a particular writer who writes about historical novels of sailing captains in the Napoleonic era, and one of the captains is always getting aphorisms wrong. He says, well, the heart has reasons the kidney never knows. And I thought, well, actually, the heart, kidney, and lungs have cancer that the brain never knows because we don't want to think about it, which is why I want to start with something I talk about a lot when I give speeches to cancer groups and patient groups. The purpose of cancer detection is not immortality. It's to lead a healthier lifespan, not just a longer lifespan. And in order to do that, we have to have a partnership between your brain and the people here on this panel who are trying to save you from cancer by developing new technologies, by letting you know what the guidelines are, when to get checked for what, and what your doctor is going to think about it, and what the payers are going to think about it. Now, I'm an awful person to lead this panel because I'm a man. And men have this problem that we don't need to go to the doctor. So I ended up in the hospital for 6 days in December with pneumonia, COVID, hypoxia, malnutrition, which is hard for a white man in Bethesda, Maryland. And my cancer drugs were the part of the problem that started that chain. I denied it for 3 months until I had to go to the hospital. So I'm starting every speech I ever give now by telling the men, and I do mean the men because women are the healthcare givers of the world. Listen to your spouse, your partner, your friends, and go to the friggin' doctor before you have to go to the doctor. So now let's get into what we're going to talk about, which is how can we find out that you have cancer with the least amount of information? Because frankly, most people don't show up to the doctor and say, I want to take every cancer test, I want to take all the blood tests, I want to make sure that you scare me to death before I leave today. That's not how it works. People go to the doctor for cancer when they feel a symptom. They can't swallow water even, or they're coughing all the time, or they've got prostate cancer and they're starting to feel pain and having problems, or they feel a lump in their breast. Those are the reasons people go to the doctor, but by the time you're aware of it, it's often too late. Now, the good news is we're able to treat some later stage cancers. We're doing much better in breast cancer, testicular cancer, prostate cancer, lots of cancers we're doing so much better. But in order to catch lung cancer, liver cancer, brain cancer, cervical cancer, ovarian cancer, all the pancreatic cancer, what I call the occult cancers, we have to have a system that doesn't rely on you feeling it. We need to have technologies that can see it. And that's why we're here today. So I want to start with Helmi from Guardant to give us a little overview of how we got here in terms of single cancer detection tests and what the future might look like for pan-cancer tests. And then as we go through the course of this panel, we'll talk about new ways to detect cancers in women that are more suitable to a good lifestyle. We torture women to test cancer in women. We want to talk about the policy and regulatory issues. We want to talk about the response of the medical community. A friend of mine asked me earlier today, should I get test X for cancer? He said, Mike Milken told me if I don't, I'm crazy. My doctor said if I do, I'm crazy. That's the dilemma. That's the dilemma we all face. So I'll start with you, Helmi. Can you catch us up with where we are?
Yeah, so I mean, obviously the field really started in this sort of stepwise systematic way where, you know, if I want to detect a particular cancer, I concentrate on that organ system. And so for colorectal cancer early detection, it's a colonoscopy or a stool test. Mammogram, or a breast cancer, it's a mammogram. For lung cancer, for smokers, it's a low-dose CT scan. PSA for prostate cancer. The challenge with all of these different single modalities, though, is really the act of compliance. We think about something like colorectal cancer. There are 50,000 people that die from that disease each and every year. 76% of those deaths come from the unscreened population. So clearly we need other options for these patients that are much easier to sort of comply with, adhere with, because screening does work for at least the major cancers that are out there. We just have to get people to do it. And so a revolution really happened, I would say, about 10 to 15 years ago, where one of the unifying properties of cancer, of a tumor, is that they're growing rapidly. And when they grow rapidly, they're also dying rapidly. Those cells, more often than not, are turning over. And they're shedding their unique DNA into the blood. And so this is a field called liquid biopsy, where essentially you can take a tube of blood from a patient and essentially be able to extract that sort of waste DNA that's coming from cells around the body, use advanced biochemistry, machine learning to decode those molecules, and then determine essentially that there's cancer in that patient, and sometimes even what kind of cancer is there. This field has already revolutionized late-stage disease treatment monitoring and treatment selection. There is tests by a number of companies, including ours, that are now used in about 40% to 50% of all stage 3 and stage 4 cancer patients today. And so essentially, instead of getting a tissue biopsy when someone's diagnosed, to understand what's genomically driving the disease and then match them with the best therapies, we can now take a liquid biopsy or a simple sort of 2 teaspoons of blood from that patient, unlock what those molecules are, essentially infer what the genome is, and match them to the best therapies. And so what we're seeing now is, as that technology has gotten more and more sensitive, we've sort of gone from stage 4 to stage 3 to stage 2 to stage 1. And so we're really living in an exciting time where essentially a blood test could be something that could detect essentially dozens of cancers at an annual physical. Obviously, there's always challenges, but we've come a long, long way from where we were 10 years ago.
Thank you. Ani, you're at Sloan Kettering. From a doctor's perspective, what is your reaction to the issue of false positives, false negatives in early detection, and how do doctors want to use these technologies, and why would a doctor tell someone not to do a test that Mike Milken says you're crazy if you don't do it?
Correct. So thank you, Greg. So a false positive test is a test wherein it designates a patient or a person as having a signal when there is no signal. And that sort of builds upon a statistical premise called sensitivity. Now, the reason why that's important is all the downstream activities that sort of are generated from a test, false positive or true positive. And first of all, that is, so it's worth flagging that a lot of these tests are not, they do not generate definitive diagnosis, so you must do additional testing. And some of these tests are particularly invasive, like a biopsy or a colonoscopy. So our feeling, the scientific community feeling, is the way to sort of really maximize the efficacy of these tests, the value proposition, is to actually really concentrate it in those most likely to benefit. And that's what raises this idea of risk assessment, right? And so risk assessment really looks at an individual, his or her background, genomic sort of profile, family history, environmental exposure. And based on that, you can sort of like stratify people into high risk, medium risk, low risk. And what that does is, in the high risk population, it really sort of increases or improves the signal to noise ratio. So a test, positive or negative, is increasingly more likely to be accurate or more precise in that setting. So that's sort of where this idea of risk assessment comes in, and I think it's particularly important. A few more things I do sort of want to just touch on. One being that I'll say a lot of these tests, so like multi-cancer detection or detection tests, I think there's a lot of nuance that should be brought into the conversation. The first nuance is, one, They do help identify many cancers that don't have a screening modality, so there's a huge benefit with that. However, for a lot of cancers, there's no definitive diagnostic test. So what that does is it may generate what's called a diagnostic odyssey, where you scan someone or you do a colonoscopy or some other approach, you find nothing. Where does that leave people, right? So was that test a true positive or a false positive? Was the lack of identification reflecting having no true definitive test for that? Or was that reflecting a pre-malignant state that is concerning? So I think that's a bit of nuance that we need to think about as we move forward in this direction. But most importantly, I think for any test, the coin of the realm, the sine qua non is, does it improve outcomes, right? So there's a discussion on, do these tests identify who they're intended to? But I think the much more relevant conversation is actually, do they materially change a trajectory for an individual, right? So,
what is the hurdle at Sloan Kettering for a test to be adopted?
So that's a great question, Greg. So
that's my job.
So many reasons. So I'll say institutions like Sloan Kettering, our role in the ecosystem is really thinking about the entire life cycle of a cancer patient, from early detection to high risk to treatment to end of life and survivorship and everything else. But as we help create new knowledge, there's that translation into implementation. And a lot of that depends on, one, what's the quality of the evidence base? I think it's probably the biggest driver, to say, okay, how compelling is that? So the gold standard is a randomized control trial, right? So I'll say right now, in the multi-cancer detection test, there's one happening right now in the UK, NHS, about 140,000 patients, that is gonna say, these tests, less about testing performance, but actually, how do they impact downstream? In this case, they're looking at, if you do a test versus a screening, which population are more likely to present with late-stage disease as a primary outcome. So evidence like that, I think engenders practice change. I'll say there's a culture aspect to it, there's a peer pressure aspect to it, there's an incentive dimension to it. And there's also what's the regulatory environment that enforces practice change as well. So that's where the state and federal government comes in. So many things come into it, but they all come to bear in adoption in the clinic.
How controversial is it when these new tests come out inside your institution? Are there warring camps, like we should adopt this test or we should not be doing these tests because of the reasons you mentioned?
No, I'll say we are more, I think there's never a unified position in any organization, but I think for MSK, we're pretty aligned that we need to see more data, more compelling data. More data anchored, what I alluded to, which is, does this have a downstream impact on the outcomes that matter, which is survivorship? That's what we're looking for. I mean, our chief of medical oncology, Deb Schrag, was the lead author on a recent paper in Lancet called the Pathfinder study. And that study really more spoke to the feasibility of these tests. And it raised as many questions as answers with respect to how they perform. So I'll say that our position is more data coming, but also to your question, whatever the data comes, working with the entire ecosystem, payers, innovators, patients, to create clinical practice guidelines, which don't exist today around these tests. So I'll say recognizing what we represent in the ecosystem, certainly we will be a major driver of that conversation. But I think the first step is compelling data.
Thank you. So let's get into a specific case of cervical cancer screening. Kara Egan from TEAL, T-E-A-L, has been dealing with the issue of, well, it's a health equity issue, but it's also a quality of life issue. If you torture someone to test them for cancer, they're less likely to show up. So talk to us about what TEAL is doing and how you want to change cervical cancer screening.
Perfect, thank you. So TEAL is working to create the first FDA-approved at-home cervical cancer screening. And maybe it's helpful what we realized before in this talk, that a lot of times we don't really understand the cancer screening guidelines or even what we're supposed to be doing. So just to kind of level set cervical cancer screening in the US. So it is a recommended screening for all women ages 25 to 65 years old. before we had a recommended screening, which is commonly referred to as the pap smear, or the pap smear was the very first test in the 1940s, cervical cancer was the #1 cancer-causing death for women. So we instituted a cervical cancer screening, and it had a profound effect on reducing death by more than 50%. Since then, we've learned, so the pap smear looks at cells to just say, have they changed? Are they precancerous? Are they abnormal, normal, precancerous, cancerous? Over time, we learned that HPV caused 90+% of cervical cancers. So we added something called a co-test, which is primary HPV, HPV, high-risk HPV, and pap smear. Since then, we've evolved a test further, which is called primary HPV, which is just looking only at HPV, and it's just a better screening. The two leading guidelines that everyone follows is the American Cancer Society and the U.S. Preventive Service Task Force. Both of them in about the last 5 years have added primary HPV as a standalone test. The American Cancer Society goes so far as to say it is the preferred test. So what we're trying to do is help bring that test at home. So we are both a self-collection device that allows a woman to collect her sample at home and mail it into a CLIA-certified lab. She then runs it on these existing primary assays. There's ones by Roche, BD, and Abbott. So that is what we're doing. And then we wrap it with a telehealth service to make it easier for women to access the screening. So she can speak with a doctor to order the test. She can have her results reviewed by a doctor. She can make sure if her results are abnormal that she can speak to a doctor and that the doctor refers her in to the triage steps. As we mentioned, screening is one piece, but it's really important that you take the triage steps. That's really where we save lives. Currently in the US today, 50% of women don't take the follow-up step within the next 12 months after having an abnormal cervical cancer screening. So for Teal, one of the things we really care about is how do we not only increase access to screening by making it at home, but how do we also continuously educate somebody and make it easier for them to go back into the office if there's a triage step. And so we're really passionate about how do we engage a woman, how do we make sure she understands it's important. Right now in the US, 1 in 4 women are behind on their screening. And the barriers to access range from, I guess there's a lot of men in the room, so I should probably also, I won't get too graphic for you, but the experience of getting a cervical cancer screening is quite invasive. It's uncomfortable. A woman is in stirrups. There's a speculum involved. It's not comfortable. And for a lot of women who've experienced sexual trauma, it can be very off-putting. Additionally, the other barriers to getting screened are just showing up into the office, right? So we're really lucky that the Affordable Care Act made a lot of preventive care no cost sharing, but that doesn't mean there's not financial burdens of taking time out of your day, traveling somewhere, transportation, child care. So these are all barriers that we're trying to address. So we're trying to address the fear, discomfort, pain with a self-collect swab at home, and then we're trying to address bringing telehealth into the home and making it far more accessible for all people to access this screening.
Thank you. Awesome. Before I forget to mention it, you mentioned it. Many years ago, the American Cancer Society did a study, and the single biggest determinant of who gets cancer is and how to avoid dying from cancer is whether you have insurance. Mm-hmm. So if there's anybody who thinks that the Affordable Care Act was a bad idea, get over it. 35 million more people are insured because of that bill. That means a whole lot fewer people are going to die from cancer just from the fact that they can go to the doctor. Simple fact, they can go to the doctor. So Larry Kessler has a long and storied career at the FDA, now at the University of Washington. Larry, what are the policy and the regulatory back and forth about early detection tests, a variety of technologies, the cost of those tests, what you have to do to show they mean something, and how we can make them available to everybody.
Well, how and whether we should. So
And how and whether we should.
I'm going to try and grab a few comments from Helmy, from Ani, and from Kara before we get back to that. Because believe it or not, cost turns out to be one of the least discussed items in all of this, which is surprising in medical care. So I'm going to give you another number. Helmy mentioned something about colorectal cancer specifically. So what are we talking about globally about multi-cancer tests? Around 600,000 persons die per year of various cancers in the United States. Around 400,000 of them, 65%, are due to cancers for which we do not have recommended screening. So it's a rich source. And now you heard from Helmy, we can discover these, or many of these, with a simple blood test. But it isn't that simple. It's not that simple because of things that Ani mentioned. And he mentioned two contradictory things. He mentioned We're looking for outcomes. We want to make sure we're extending people's lives. But he also mentioned the endpoints for some of the current studies going on, particularly in the United Kingdom, of these multi-cancer tests are downstaging, meaning catching people early. Well, you heard from Greg, isn't that the magic bullet? Just catch everybody early. No, it's not. And it's not for a couple of reasons. And there have been some recent studies that show why it's not. And so it's a real challenge for us. So one reason is in certain cancers, moving people downstage just extends how long they have cancer. Sometimes with less morbidity, that's good, but it may not change the end of their life. So you're just telling people, you have cancer for a longer period of time. And we saw some of that in the early days of the prostate-specific antigen test in the 1980s, which turned out to be a really challenging period for looking at screening for prostate cancer. So now we have a whole bunch of people we can tell you may have cancer. We need to figure out whether we're going to do them any good. And some recent studies in ovarian cancer where we downstaged people, Ani knows this, that we didn't extend mortality, extend survival. So it's not so clear that you can always do this. And one of the challenges is that you mentioned a really lethal cancer that if you've ever seen anybody die of it, it's horrible, pancreatic cancer. One of the problems we have is that if we detect it early, we're not sure what to do. Yeah. Why? Because we don't see enough of them to actually do clinical trials. So these early detection tests actually have the potential to hand patients to Ani, his colleagues, Deb Schrag and others, to try trials with new molecules. So there's going to be new opportunities. But whether they will work and improve lives and extend lives, we don't yet know. So we have to be careful not to release this on the public, and that's what the policymakers are asking about. And you said, are there controversies at MSK? They're national controversies. So the National Cancer Institute is taking a very stringent position about trying to do mortality-based trials, which we don't think are going to be around answers with for 10 years. That's a long way to wait. Okay? But the shorter trials that can look at something like stage may not be definitive. So trying to balance that at the policy level from the FDA and from a group that Kara mentioned, the U.S. Preventive Services Task Force, they're very conservative. So they're going to wait for mortality data. They're tough. I want to finally wrap back and to say something that will connect with what you heard from Kara. If these multi-cancer tests get out, one of them actually now is on the market as a lab-developed test, they're expensive, $1,000 a pop. Who do you think's getting them? I'll tell you, it's not poor people. It's not people who don't have access to care. So I think what Kara is trying to do in Teal couldn't be more important, and we need to think about that for multi-cancer tests to make sure if they work, they're widely available. And that's a political and policy controversy, right? So I hope I've answered some of your question.
Yeah.
Can I jump in? I think Larry raises a phenomenal point. One thing I want to double click on is, with humility, I think the scientific community is not 100% confident that every cancer follows a stepwise, pre-malignant, invasive, advanced, metastatic. That is not the case for every single cancer. So which then raises the question, some cancer may just present advanced because that's a typical trajectory. First thing. Second thing, Larry said this accurately. He used the situation, one I like to recommend is papillary cancer. Sort of getting papillary cancer early does not really lead to a life expectancy. It leads to something called a lead time bias, right? And sort of when you think about this paradigm, which makes sense, you get a cancer early, it's less costly, less morbid, probably more effective. That is not reproducible across all cancer types. So I think that's a bit of nuance that we have to sort of talk about.
Yeah. You know, Larry, you brought up something that I want to comment on in terms of clinical trials. Since time began, we've been doing these random clinical trials that take a long time, and people in them, you know, if you were in a phase 2 trial and it stopped or it was done, you had to wait for the phase 3 trial and you don't get the drug in between. It's not pretty. We're moving past that now with something called N of 1 trials. There are nonprofits. I'm on the board of Cancer Commons, which is one that if people have an intractable cancer, they show up and they immediately start trying to use approved drugs for different indications for a particular patient. Now, clinical trials are not about particular patients. They're about the population. There's a company I met in Europe that's doing an N of 1 process whereby they find people who survived the worst cancers and they reverse engineer their genomics to see what was going on as a way of learning how do you survive that cancer. And these were not people who had treatments for those cancers. These were people whose body fought the cancer. So and now, because of data that we're finally gathering from electronic medical records, and because of AI, I don't want to talk about AI, I've talked about it all day yesterday, and I'm losing my intelligence. Now with AI, we can understand a lot more about what's going on. Full disclosure, I'm an advisor to 2 different cancer detection companies using very different technologies than here. One analyzes medical records, one analyzes stem cells. And in a study at Mayo, the study of looking at medical records for subtle changes indicative of cancer, they found that 20% of people who were diagnosed 5 years later could have been diagnosed 5 years earlier, just from their medical record. No biopsy, no blood test, no invasive procedure, just things that people don't see, but AI does. That's pretty heavy, and that's part of the future of what's going to happen next. But let's shift to you. Jody Hoyos is the CEO of the Prevent Cancer Foundation, which has been around for over 30 years and has been fighting the good fight against all odds because people are really bad at doing prevention. Jody, how do you approach your job and how do you deal with the human brain because 30 years ago, preventing cancer and getting tested was a dream.
Right.
Now it's a reality that people don't engage with.
Right.
How do you get up every day and go fight that fight?
It's a fight worth fighting. I mean, I think that it is a no-brainer to everyone here, to individually, collectively, that prevention and early detection is the most effective way to improve the health of our society, bar none. Prevention is where it's at. It is also the place where we invest the least. So that is, if we can move that needle at all, it is worth doing, and we can. And it's happening now. I mean, and in defense of people and not doing what they're supposed to do, I mean, we are ultimately a people advocacy organization. People do not know what they need to do. So right now, 7 out of 10 people are behind on their routine cancer screenings. And to Kara's point, there are 5. So you have prostate cancer screening, cervical cancer, colorectal cancer, lung cancer. Which one did I forget, Larry? Breast. Thank you. God, the big one. Right.
Can't forget that.
Okay, so there are 5. It is incredibly difficult for people to keep track of what they need to do and when. So when you ask those people, why are you behind on your cancer screening, or why aren't you getting them? The number one reason, regardless of race, ethnicity, gender identity, is they simply didn't know they needed to be screened. If we ask this very well-informed audience when they need to get their cancer screenings or when their families need them, there would likely be challenges in answering that question. And this is a group that likely has a healthcare provider to go to. The second most common reason cited is that people say they don't have a family history of cancer. It is important that people understand their family history if they have one. Maybe we've over-indexed on that. People really assume that if I don't have a family history, then I'm fine. The reality is the vast majority of people with a cancer diagnosis do not have a family history. About 10% of cancers are hereditary. And lastly, and Greg mentioned it earlier, it's the signs and symptoms. So if you don't have signs or symptoms, you feel fine, then you're not going in to get your screening. There are many barriers to getting cancer screening, but I think this awareness piece can't be understated. And as we navigate this landscape of the innovations that are here and the innovations that are coming, and they are coming, and I think it is to the betterment of all of us that we change this space, is that we have to be working together to ensure people understand what the hell this means. It is going to become incredibly more confusing as we introduce more, unless we do that. And we're tying the screening recommendations into this kind of more of a broad doctrine. the last point I want to make about our way forward too is what you'll hear a lot in the healthcare space. It's in every conference and every conversation, I'm sure I've said it a few times, is meeting people where they are. You hear it all the time. Let's meet people where they are. I can assure you, people are not hanging out by low-dose CT machines and mammography equipment. And yet, there's a real challenge in getting people, getting us collectively to say there really is something about these liquid biopsies or blood tests. The biopsy language I don't love because really it's a screening. It's not a biopsy, but whatever. So these blood tests and other innovations about truly meeting people where they are. So we have to kind of balance those two. And every time someone says meet people where they are, I say, how do you feel about blood tests? And it's like, So, I think we have some work to do.
Wow. In 2007, Faster Cures helped launch the Melanoma Research Alliance. And I developed med school hypochondria studying melanoma. I could barely shave without thinking I had melanoma. And what I learned reading the literature was that nothing was working. So I talked to a cancer doc I knew very well, and I said, we're bringing all these famous people in, including Jim Allison, to talk about melanoma, and nothing works. How can I start the conversation? He said, why don't you just say that? Nothing works. So I did. And that was in 2007. And we had old guard doctors who'd been doing this for 20, 30 years. And we had young doctors who were not getting a whole lot of attention because they were doing this new thing called immunotherapy, which had been as we say in Arkansas, the redheaded stepchild of medical therapies. Nobody thought it was real. Well, turns out it's pretty much the only thing that is real. So now people who were dying of melanoma in 2007 can actually be treated. And if you catch it early enough, and even if you don't, immunotherapy, I have met 25-year-olds who got out of hospice because of immunotherapy. So the problem now is, even when we can deal with it, it's hard to ask people, it's not hard to ask them, it's hard for them to do it, to say, you need to, you're really freckled, you're white, you're in the sun all the time, you need to get checked for melanoma. And if that's not good enough for them, tell them if you catch it at stage 1, it's easy to treat. After that, it always comes back. And if that doesn't scare them, then you're just out of luck. So the flip side of everything that's going on here in order to check your cancer sooner is that we have to be developing treatments so that it's not just, as Larry said, telling you have cancer for a lot longer in your life. So 30 years ago, if you had leukemia, you died. Today, there are about 30 treatments for CLL, which I have. And I met a man who had leukemia in 1991, and there was nothing. And he saved his own life through a variety of things that he did. And that's really hard to do. It's hard to be a superpower. So we're going to move from single cancer test to pan-cancer test probably sooner than we think. In the moonshot in 2016, we got so much incoming, we've cured the testing problem. And of course they had not. So we started a consortium that's still operating today. It's called Blood Profile Atlas Consortium. The Atlas part is classical. And Atlas tells you where things are and what they mean. This is a mountain, this is a river, this is an ocean. In the blood, there's all kinds of things, and a lot of it doesn't mean anything. It's detritus. Some of the detritus is from a tumor, and that's how some of these tests get started. But we want to find it before you have a tumor. Now, colon cancer is different because it's slower, it's easier to fix, it's easier to find, but you got to show up. So here's the next question. How do we do these tests on a minimum amount of data from people? The most minimum amount of data, because people don't show up and say, do a full body biopsy on me with the genomic sequencing, here's my 50 years of medical. They don't do that. But they do get a physical to get in the military, physical to get into college, physical to go on Medicare. And a lot of people do a physical every year, every other year, which is how I found out I had leukemia. I didn't have symptoms. I just did a physical, and boom, I had leukemia. So I'll never do that again. That's how most people think. I'm sorry I went. Where do you see the technology going for pan-cancer tests? And what is the least amount of data we'll be able to do those tests on so we can capture people who are not going to walk in and say, test me for cancer?
Yeah.
Start with you, Helmi.
Yeah, so we think a lot about this. So I think one of the driving forces in terms of what has enabled these types of tests most recently is the really precipitous decline in sequencing costs. If you think about the first human genome was sequenced anywhere from an estimate of $100 million to $3 billion, depending on what you count. And now we can sequence genomes for $200 or $100. And so it's outstripped Moore's law in terms of the exponential decline in sequencing. And so, our blood tests, when we take a blood test, we're generating something like, I think, like 10 terabytes of data. Compare that to a CBC or a lipid panel or so on, where you have just a few data points. And so we're in a completely different realm in terms of the information we can extract from a tube of blood. And within the next 10 years, just think about it, it'll be like an almost infinite amount of data. It won't just be DNA, it'll be the whole proteome in the blood, it'll be metabolites, it'll be a whole bunch of things that we're getting from that single tube of blood or that single blood draw. And so the big challenge is going to be, how do we process that data? How do we correlate it with different conditions that are there? And I really look at this as a sort of new realm where, you think about the advent of the internet, and we're all, I think, marveling about the ChatGPT moment like about a year ago. But what enabled that was the fact that every human on the planet put 100 quintillion pages of information on the internet, essentially their thoughts and communications and so on. So the data was a sort of key milestone and impetus to getting there. And that's what these blood tests are going to do. Essentially, they're going to allow us to populate essentially this corpus of data so that we can start correlating these conditions. And we're starting small, just like smartphones started with a camera, MP3 player, a music player, and just and the cell phone. But essentially, it had a computer in it, and it had capabilities to do a lot more. And that's the same thing. These blood tests, I look at the sort of equivalent of the smartphone, where right now they may be just detecting colon cancer or a few cancers or multi-cancer, perhaps not with the sensitivity that we need for some of the more occult cancer types. But over time, as we process this data and we analyze it and we add more biomarkers and we have a continued exponential decline where we're detecting 1,000 more times biomarkers per tube of blood, we're going to get to not only exquisite detection of cancer, but we're already seeing signals for inflammatory disease, cardiovascular disease, and so on. So imagine that blood test at an annual physical is screening for thousands of diseases, is the co-pilot to your primary care physician, and maybe someday replacing your primary care physician. But I don't want to get too controversial.
Jody, what did, even better than early detection is prevention, as you said. The HPV vaccine, how many people had teenage daughters when the HPV vaccine came out? And was it controversial in your household whether they should take the vaccine? Nope.
That's good.
I told the story earlier of my wife and a group of her friends were talking about, well, what about 20 years from now? Maybe it'll be bad. Maybe it'll cause infertility. They thought of all these things. And my teenage daughter walked in the room and said, I'm getting it. You guys can talk all you want. I'm getting it. Jody, what did we learn from that experience about people?
Yeah, people are beautifully complicated. Beautifully complicated. So the HPV vaccine, for those who have not thought about it before, can prevent up to 6 types of cancer. When we talk about cancer vaccines, we have one. I mean, it is a big deal in terms of our ability to eliminate cervical cancer and drastically reduce many others. The HPV vaccine, we were doing quite well as a country, certainly behind many other countries, but we were doing well in terms of uptake of the vaccine in boys and girls. So it is both for boys and girls. And we've taken a dip. So what we've seen is a decline in vaccination rates across the board, and HPV vaccine being one of those. There's many challenges with that and kind of what that means for us. But, kind of some corollary data that I think is important too in factoring in this provider overload question that maybe Ani or Larry can speak to too, is that when we survey, we do an annual early detection survey to get a pulse on what's happening with behaviors and perceptions around screening. One of the things that we know, and we know from other data, is that the conversations we often say in our messaging, for many of us, talk to your provider about X. Okay, well, many people don't have a provider. That is not a normal part of their life. The second part is when you find out about the number of people having conversations with their providers about screening or prevention, that rate is declining steadily. So we're seeing a very downstream impact on their ability for providers to even have these conversations. So what we've learned is that, again, it goes back to people don't know what they need to do. If they do know what they need to do, they still have questions or not. They don't have a place where they're able to ask those questions.
Tara,
Yeah.
doctors, as Ani mentioned, doctors are notoriously conservative about adopting new technologies. How are you going to get OBGYNs and other physicians in the boat for your new test?
So we're lucky, I think. We'll find out. But so first of all, it's not a new test. So the nice part is it's the same test, it's just a new way of collecting the cells, right? And so that's important in terms of not a big cognitive change about what we're willing to do in terms of testing for cervical cancer screening, which is the primary HPV. The other thing, to Jody's point, is that doctors are overworked, right? And so if a patient is even going to a preventive care visit, it's predominantly with a primary care doctor. Women get 2 annual visits a year covered, one with their primary care and one with a women's health specialist. Kaufman Foundation found that only 9% of women have a regular relationship with a women's health specialist. So basically, all of these women are not going and getting these screenings done with their OB-GYN, they're getting it done with their primary care. Their primary care doctor has 15 minutes, if even, to cover the entire year and your entire body. And so what we've been lucky with is basically almost every primary care doctor is like, I know that this isn't a good experience for my patient. I don't have another option, but you know what I saw? I saw colon cancer go this way with fit kits and Cologuard. And we saw wild uptake, and especially during COVID when you saw that was the only cancer screening that stayed on track. And so what's nice for us is we have doctors who understand the importance of it bringing home and how it's actually going to increase screening. And we don't really take from in fact, we give them more time back into their office. Approximately 30% can be taken because it's the only reason why you have to get undressed or dressed in the room. A lot of healthcare systems have to have a female chaperone in the room, so it's double the resources. So we're actually not being met with much objection.
Super.
Yeah, I know. It's great.
Good on you.
Yeah, thank you. Good on the doctors, right? They're overworked and they just want something better. We just didn't have something better before, or we still don't. We're still on our way through the FDA, but we're getting there.
So I often joke that in my hometown in Arkansas, you can only get cancer on Tuesday and Thursday because that's when the doctors came over from Memphis. And I thought that was probably fixed by now, but I gave a talk a month ago and I looked it up and it's not fixed. My hometown does not have an oncologist, 25,000 people. You have to drive an hour to Memphis and you'd have to get a room if you have to be treated there. It's complicated. So Sloan Kettering is a phenomenal institution. I did chemo there for my leukemia. It was, as chemo goes, it was a good experience. Can you talk about your relationship to community hospitals and how Sloan Kettering is helping to make sure that we get these new treatments, tests, et cetera, and care to community hospitals that don't have near the resources or people that you do? But I know that you have a active program in that way. Can you talk about how these tests can get out there?
Yeah, so thank you, Greg. So at Sloan, we're evolving our model, but essentially sort of push expertise to the community through many ways. I think one, the most material one is through partnerships. So we sort of have engaged a variety of health systems, local, regional, and nationally, through partnerships, wherein we sort of transfer our protocols, our pathways, and hopefully elevate the standards of care in those communities for the betterment of the residents. So that's one way we do it. Another way is just sort of like through the scientific literature, sort of like disseminating knowledge that way. I think a lot of practice change and adoption is born from, like I alluded to before, sort of what the literature and the evidence base is, and then also having sort of a local community adopt it and sort of enforce through sort of like peer control adoption. So that's another way we do it. And I think the responsibility, is worth flagging that most cancer care happens in communities, about 80%, not in the Sloans or the MD Andersons or the City of Hopes of the world. So I think that environment is critical, that it deliver care as good as you can find in academic medical centers. And that involves providers, that involves clinical trials, and that involves sort of relationships with those academic medical centers to make sure that the care standards are as good. Now, I want to be not have a bias. Just because we're academic doesn't mean the care is always the best in class, right? So I think with some humility, there's a lot we can learn around cultural competency from those providers as well. If you think about it, as the U.S. demographics evolve to become more minority-majority, then sort of tapping into those sort of socially disadvantaged populations, those rural populations, requires a certain expertise that candidly places like MSK and other academic medical centers don't necessarily have in-house. So there's a lot of cross sort of pollination on both sides to sort of deliver high-quality care to all patients. Larry?
Larry, you want to respond?
Yeah, what Ani's speaking to I think is really important and connects with some of the things that Kara said. We have very low health literacy in this country already. Mm-hmm. And now somebody like Helmi's talking about having terabytes of information on everybody. And I think that will probably blow a lot of people's minds, but they really want to understand it. And I think we have an obligation, like Ani mentioned, to do a better job communicating to a variety of communities about what we can do for them and why. And then we need to do something else, I think, something Medicare did in the last year, which we need to translate to less privileged populations. And they now are paying for patient navigators if you're Medicare. Not in Medicaid, not in federally qualified health centers, but that would be critically important because you need community involvement, and that would help Teal Health do its job because you need to get to the community and need to understand that we're providing something that can be routine, can be simple, and can save lives. And it's really critical. And I want to speak very highly of Jody and the Prevent Cancer Foundation because it's really important when you can prevent. Interestingly, speaking of Helmi's work and Kara's work, the two cancers where we actually, other than lung cancer, stopped smoking, which you never should have started in the first place, but for cervical and colon cancer, what we're doing, we call it screening. It's actually prevention because it's not the effectiveness of screening. You're actually catching pre-disease. And when you catch pre-disease, then you're better off tremendously. And we don't have that with all the other cancers yet. And maybe all the information Helmi's talking about will help us get there. But I think what it's likely to do is tell us a lot more about differentiation of cancers, some of which will then go into the treatment category, and some will try to figure out how to manage better in the community. But we really need to connect with communities, and we need resources to connect to communities, and we need to support the political will and the resource to make it matter to people in those communities. And we're not good at that.
One other thing that I want to sort of underscore what Larry said is it's so important that it's truly bidirectional because an element of trust, right? And I think sort of working with these trusted providers in your hometown that you see in the grocery store, that's a therapeutic value to it, actually. I'll say more so than any provider coming in from the outside. I think that trust factor cannot be understated, right? Yeah. And I think that bridges cultural competency, bridges relationship dynamics, and is less paternalistic if it comes to that lens. So I just want to sort of speak to that as well.
I also think, sorry. Still, it's a hot topic. the point I want to add on to that about building trust within community, particularly as we look at what's happening now in the pharmaceutical space and the mandate to diversify clinical trials, it is really important that as that approach is underway and looking at communities and trying to build trust for enrollment in clinical trials, that you need to be there up front. So if you are not there for their wellness and trying, treatment is critically important, and everyone should have the ability to enroll in clinical trials. Be there up front as well. I mean, that is missing right now, and it is something that we really need to make sure that we are almost mandating as a society. Be there for me when I'm well. Be there for me to help prevent, detect early, and then join. We'll be with you through the treatment as well.
And also, include me, right? So
Right.
we just finished our clinical trial. I mean, it wasn't until 1993 that women were required to be a part of clinical trials. So women have not been involved, right? So we just did our clinical trial. It was over 600 women. We were over-enrolled by over 33%. It finished 2 months early. Anecdotally, we saw an 80% participation rate when asked to be a part of it. Like, women want change. People want, to that same point, like our number one enrolling group was 40% Black. It was 60% under $50,000 income. Like, we built the study to look like the people we want to help, which is everybody. I mean, it went all the way up to everyone was involved. And it was 17 sites, but it was when you design for and you include the people you're trying to reach, like, magic can happen, right? And so I'm just so proud of our study. And when you start early, to your point, to designing for who you're really trying to reach, it matters, right? And it shows up. I mean, when we talk about our product, we're not talking about a kit that's cost savings. To me, it's a kit that can create a relationship and welcome women back into a trusted health situation, right? And I think that we so often think that it's that one-to-one relationship with a doctor. I think we can leverage technology, quality videos, visuals. Like, there's many ways to build trust. It's not always a conversation. And so I think we need to start imparting that in lots of other parts of healthcare if we want to have people engaged.
You have a QR code for this session. If you want to submit a question, go to that QR code, and then it'll pop up on my little iPad, and then I'll ignore it. Not really. If it's a good question, we'll bring it up. It's funny you should say that, the building the relationship, because men who get checked for prostate cancer, it's a pretty intimate experience, and it's a relationship. I remember the one time I got checked, and I was working at Pfizer. And during the procedure, the doctor wanted to know if I had any investment opportunities in the drug space. And I thought, wow, isn't this nice? So, I mean, we've got a long way to go to create relationships. Let's talk about money for a minute. Larry, Helmy and I were talking about this before the session. You would think that if you have a valid early detection test that is accepted by the government, accepted by doctors, that is going to bring more people into the medical system earlier when they're easier and less expensive to treat. But that's not the way we're reimbursing it.
No.
What's up with that? Why isn't this viewed as a net positive to bring more people into the system before they're deathly ill?
Well, because bringing more people into the healthcare system almost always costs money. There's virtually no medical technology that saves cost. It's just cost for quality of life years saved. So you're adding cost to the system. And for many people, companies, a lot, they don't worry about cancer in their population. They don't want to invest in it. Why? Because the benefits will be seen for the people who get cancer over the age of 65 when it's Medicare's problem. So really, I mean, it's a transfer of resources and interest, frankly, and it's not a good one. Shouldn't be proud of the system that does this, but we really place a low value on detecting these diseases. But one thing you have to remember, and it goes back to what you said about symptoms, because I've done a lot of work in looking at symptoms. There are very many vague symptoms that show up in primary care offices that actually are indicators of cancer, but if you act on all of them, it's going to be massively expensive. Unintended weight loss, persistent cough, persistent bloating, which may be related to ovarian cancer. If you go after every one of those with a cancer diagnostic test, costs will go up. So you have to really balance which of these are you going to look at and not. And that's why some of the work that Helmi is doing is so important, because then you try to figure out who are the right targets. And we need to do that in a smart way so that we're not bankrupting the system, but doing it intelligently. And we're still learning about it.
Yeah. Helmi, how torturesome has this process
Yeah, it's been tough. You know, our first test that we launched was 2014 for late-stage patients. These are expensive patients. And this is an area where replacing tissue biopsy with a blood test actually does save money. The average lung biopsy costs $14,000 because of the complication rates. A lot of patients, when they're not tested properly, are they're put on expensive drugs like immunotherapies, and obviously immunotherapies have great outcomes for a certain subset of patients, but they actually don't have great outcomes for a large subset of patients. So you have to be the right type of patient, versus many of those patients can be on cheaper drugs, targeted therapies that work really well. And so this is an example where it's a win-win-win. It's a win for payers, a win for providers, and for the patients. Yet it's taken us 9 years to get reimbursement from United and Aetna, despite now reaching 500 peer-reviewed publications and essentially have FDA approval and so on. And so I often say that the biggest impediment in healthcare is not necessarily technological innovation, it's sort of business model innovation. It's actually how do you figure out how to get that test accessible by all in the system? I mean, the last thing I'll say is that, why would we expect it to be any different? I don't think there's any other industry that still uses fax machines and pagers. Something like 40% of our reports still go out with fax. I mean, same thing with Quest and LabCorp. And so, clearly the natural laws of technology diffusion don't work in healthcare.
I want to give each of you a little under a minute to say what you hope to achieve in this area in the next year. And I'm going to start with you, Ani.
Clarity. That may be too soon given the timing of the UK trial, but I think clarity with respect to who, when, and what, as much for the test as is the downstream activities that flow from that test. And where we'd love to end up is for each given patient on his or her journey, what's the right time point to deploy the test, and what's the right follow-on activity that gets to the best outcome with the lowest cost structure. That's what I'd love to see us evolve to.
That's excellent. Larry?
In addition to the clarity, which I think we badly need, I'm very passionate about health equity, because I think these technologies, if they're available and if they are worth it, which we don't know, but I really hope that we don't continue to make the same mistake in the United States to not get them out to the populations that desperately need them in minority communities. We're not good at it. We need to fight the good fight.
Yeah. One of the very first projects of the Cancer Moonshot was a collaboration between the University Hospital in Cleveland and GW in Washington to go into housing areas where there's a high volume of smoking, high numbers of lung cancer cases, and very little detection. And that 2-city program was so successful, it's now a 20-city program, which is critical. Jody?
Greater collective investment in reaching people with the information that they need, and truly involving their perspectives and what they want and don't want in their healthcare experience is critical. We've talked about patient-centered care for a long time. It is not patient-centered.
Yeah. Helmi?
Yeah, this is a watershed year for us. We just finished a 22,000 patient trial, essentially, for screening for colorectal cancer. It just got published in the New England Journal of Medicine. We're in the final stages of FDA approval, and so we're hopeful sometime this year, first sort of FDA-approved test that is Medicare reimbursed for screening for cancer will finally be out there in the open and available to 120 million Americans.
Great. Kira?
Yeah, we're laser focused on getting our product to market to increase access for this 1 in 4 women who are behind, which is roughly about 20 million women. And we're excited that in addition to finishing our clinical trial, we were just put on an accelerated pathway as part of the FDA Breakthrough Device Program. And for everyone who's in this room trying to make change, like faster cures was involved in the Cure Act, which is part of how the breakthrough indication came about, which is the idea that if there's something that can be truly life-saving, whether it's a diagnostic or a treatment for a device, that it comes to market as soon as possible. So we're like thrilled and honored to get that designation and hustle as fast as we can. So I think within this year for sure.
That's awesome.
Yeah.
I wish Stand Up to Cancer would change their name to Screen Up.
No.
They get entire stadiums to stand up for cancer, but do they get them to go get screening? I don't know.
Happy to bring my kid along.
There you go. And the last thing is the technology that I want to remind you is the only technology that works for cancer screening is you asking someone you care about if they've been screened for whatever it is that they need to be thinking about. That's the only technology that works to get people to use all these other technologies. So I urge you, you're not spectators here today. You're part of the team. It's not easy, and it's often, you don't want to do it at the dinner table, but please ask your loved ones, your friends, people you work with, have you been screened? That is the single best thing you can do to make things happen. Thank our panel, and thank you for your attention.